the structure was set up originally by Sutton CCG, who felt that if they were going to listen to the views of patients, they needed a process by which that could happen. So they put in place patient groups at practices, and then a second tier of a borough-wide patient reference group, which would be the conduit from the patients to the CCG.
I think they've got their ear to the ground, they know the patients, they understand the health issues, they understand what it's like to work with people who may not have run a group before, may not have facilitated a group because of the work they do in Healthwatch generally. So I think Healthwatch bring with them an awful lot of generic skills, and I think the purpose of Healthwatch to support a piece of work like this are generic and they would apply in any patch.
The content of the toolkit was largely decided as a result of the survey that we did of practice managers, asking them if they hadn't set up a group, then why they hadn't, and what difficulties they might have encountered if they'd started to set one up and weren't quite sure what to do, and what sort of help they would like or what would encourage them to set up a group. So that gave the basis of the sorts of things that we felt should go into the toolkit. And then the information which we could then provide them with was drawn in part from internet resources and just having a look at the experience of other patient groups and finding some examples of good practice. And of course, as a Healthwatch based in a CVS, we also have access to a number of valuable resources in terms of good governance, templates, guidance, policies, which I was able to sort of draw on and adapt for the patient groups. The toolkit had quite a range of items, including some pretty basic information about what a patient group is, what might be the key benefits to the patient, to the practice. Then some practical ideas on how the practice manager or the patient group, if there was a number interested, could promote the group and think about recruiting other people. There were some things like templates of flyers and posters for recruitment. There was some guidance on perhaps how to hold a first meeting, what sort of things might be a good idea to raise at that very first meeting. And then in terms of governance, some things like a sample terms of reference so that groups could decide what they as an individual group would and wouldn't do. We then ran some workshops for patients who had joined patient groups and weren't quite sure what they could or should be doing, and again, understanding their role and the healthcare structure. And then for those representatives who were going on to the patient reference group, we did some further training about their role within the patient reference group. And a lot of that work has been around understanding the role of the CCG, the acronyms that are used and the structure that they're feeding into and what they can influence and how.
As a member of my PPG, we were invited by Healthwatch to attend a training workshop, and there are about 20 people who came from the various practices within Sutton. The idea was to give us all a much clearer understanding of the structure in Sutton, and also to see what we can do at our individual practices to make them that little bit more efficient, more inclusive.
I think the biggest impact at my patient group has been really being in the lead on the annual patient survey. So developing the questions, developing the methodology, actually going along to surgeries and encouraging patients to complete questionnaires, sometimes helping them to complete them because English has not been their first language, or maybe they just generally can't read very well. So I would say that's probably the biggest impact.
The practice manager was actually very grateful that I brought things to his attention, and I'm aware now on my visits to the practice that things are very much improving there. To the point where the receptions team always the first point of call with patients, and the way that they are being perceived has improved, and I've got a good relationship with the head receptionist, and I've promised her that I will say if I think anything's not right.
The group itself obviously concentrates on what's going on in the practice itself, and I think, conceit aside, we have actually done very well. We've got to the point where we are working very well with the practice. We have a core group of now 7 or 8 members who will undertake to prepare things like the annual survey on behalf of the surgery. We hold open days so that patients can come in and find out what's happening, and trying to ease the pressure on the clinicians' work that they would ordinarily not want to do. I think you will find that there is now a means of communicating with the practice without being personalised on it. A lot of people are very wary of talking to their clinicians, the nurses, about something that's not going right. They have an inbuilt fear, irrational at times, that might affect the treatment they're getting. We have an email address that's directly into us as the PPG rather than to the practice. So if the individual patient wants to say something, or indeed an individual member of staff, they can write to us knowing that it's going to be anonymised, but the point is going to be taken up with the practice. That's one of the clear ways that we're getting the patients recognising that they have a big say in what goes on in their practice.
There have been groups who have improved the patient experience in a number of ways, and some have focused on those with disabilities, so they've arranged for a hearing loop to be installed, or they've asked for, and the practice has agreed to, lower reception desks for wheelchair users. Some of the practices have focused on providing more information to patients, so improving the patient leaflet that goes out from the practice, providing some information on where people could be going in an emergency, something that a lot of people don't always understand what to do if the practice is closed. There's a couple of practices who've been looking at GP appointments via Skype, and one of the patient groups has trialled those appointments with the GP. Another practice, the patients identified that there was a need for a female GP as there wasn't one at the practice, and the practice arranged for a recruitment process, and there is now a female GP. Quite an impact at one practice where they're due to move fairly soon, and the patients will have the opportunity to feed into absolutely everything in the design and layout and provision of services at this new GP practice. At a wider level, with the patient reference group, we're just beginning to see that patients can have an impact on decisions made by the clinical commissioning group, on monitoring the services provided by them. So the patient reference group is beginning to have an impact now that it has a very comprehensive work plan which has identified some key pieces of work that it will follow through, from gathering patient feedback, exploring further through task and finish groups, and then presenting a report back to the CCG, which will be able to monitor the outcomes of that. For example, a few people complained about NHS 111, and the group are now going to set up some task and finish groups to go and actually have a look at the call centre, gather some patient feedback, produce a report, and with the idea that when the contract is up for retendering, the patient feedback on the experience of using that service will help towards identifying sort of key performance indicators for a new service provider.
I think the biggest change has been that I think it is absolutely now a mainstream part of our thinking in CCG in terms of commissioning. There isn't often that we will be discussing something, we won't think, oh, well, do we need to go, let's go and talk to the PRG about that, or let's ask the PPGs what they think about that. So I think the biggest change has been that we have this really lively group of people who have been learning and responding to lots of our engagement events with them, and so this year, it was really obvious when we took our commissioning intentions way back in May and June and said, look, we're thinking about what we're going to do next year, what do you think? And actually we've been back now 3 times. It's now nearly October. And last night we sat down and we did some group work with our PRG about our commissioning intentions. And so I really feel we've given them an opportunity to get their heads around the type of things that the commissioners were thinking about, and the managers and the GPs, and then really test that out on our population and get what they think. So that's been the biggest change. I think that now it's absolutely just something that we do, because we've got access to this group of great individuals who have something to say on behalf of their practice and their population. And I think, to continue that, it would be great if now we could then think about how we could maybe use those practices to work together, and we could actually then hone in on some of the more particular groups around pathways. So, for instance, if it was young people, access to particular services, maybe a sexual health service, it would be great to see if we could get a group of those individuals together, so we could be more specific and targeted around our approach. But because we're thinking of different ways to do that now. But yeah, the biggest change and the biggest success has been actually that's just part of our thinking. But obviously we could improve and be more targeted, I think, in our approach.
The vast majority of people who do have the time, the inclination, are generally of the older age group. We've tried to have our meetings at various times during the day in order to attract maybe the young mothers who are taking time out to bring up their children. We have a very poor response from obviously the very young members of the practice, the patients, the children. But I think through the means of setting up what we call a virtual group, we can encourage the younger people to be participants purely by email. They don't have to come to meetings, they don't have to have anything to do apart from maybe respond to the surveys, the questions that we can then ask them directly through the email.
My own strong feeling on it is that while our own practice manager has been the person who's been proactive in getting it together, some patients actually feel better talking to other patients as opposed to somebody from the surgery. So I'm proposing that we perhaps have the odd coffee morning where patients can meet patients. Having said that the initial engagement is tricky. So I'm hoping that meeting patients while I fill in this survey with them will help.
At our patient group, we've advertised the group by putting up a notice board, email address, and that's not really been effective. So I actually think that it means that the current members of the group need to talk directly to patients. I think we actually need to talk to them whilst they're waiting to see the doctor, and to explain to them how they can get involved and the difference that they can make. And actually giving them greater knowledge is empowering them, and it can be quite a selfish thing because they can benefit, and their family and friends.
So I would suggest that people might be critical because, unfortunately, many of our members of our patient participation groups tend to be adults and slightly older adults. And I think that you could say that we don't particularly represent our population that well. Although we do take people there are representatives from different ethnic groups, etc., we do tend to attract the more sort of mature adults. So that would be a criticism, I think, of just the groups and who they represent. However, we are looking at ways to encourage younger members of those groups and think about some innovative ways to do that.
We do hear the criticisms. A lot of people are saying, well, what are you doing? What impact are you having? And I think the sad reflection on a lot of people who are not a little bit more involved is that they see what we do as nothing more than maybe a tick box exercise by the Sutton Clinical Commissioning Group. They are required to have public and patient engagement. We're lucky within Sutton that they actually mean it, but we do hear stories from other Healthwatch organisations that sometimes their particular clinical commissioning group doesn't give it the full backing that it deserves. So I think we need to overcome that reluctance or overcome that cynicism by actually saying, they are doing things, this is your chance to have a say and make things happen.
It's given me a confidence that we are able at any point in time to reach out to our population. And without them, without this, it would have felt very piecemeal and very, let's just find, the most willing 20 people to sit in a room and talk about something, which isn't participate. That isn't listening to patients. That's just doing something really quickly because we have to. So it's definitely given me a confidence, and without that network, I think I'd have struggled to have that confidence in our ability to hear and to speak to our population.